I'd like to invite Professor Andrea Phelps to also join us on screen. And let's get into the questions because there's lots. So let me read the first one, which comes from Joshua Hall and reads, I think it's addressed to you, Andrea. Do you have advice on adapting the process for clients with limited literacy who have difficulty writing down the nightmare? Should the counselor just write down the sequence, or would you represent in images, drawings, or in symbols?
What I have done, and that certainly does come up from time to time, what I have done has generally been to ask the person to describe to me verbally what happens in the nightmare, and then I will write it down. But this is also an intervention that's used a lot with children. And when with children, it will often be about drawing pictures about what happens. So I think that working with the client and what their preferred modality is, I think you just follow that as your guide.
Thank you, Andrea. And there's a follow-up question also from Joshua, and it's almost word for word the question that I wanted to ask because I've had a very similar client as well. We have seen several clients who are diagnosed with sleep apnea that seems to be triggered and trigger traumatic nightmares. These have been difficult to treat, even with CPAP machines, having limited benefit along with trauma reprocessing therapies. Do you have any ideas about treatment in these situations?
I think that the reality is that despite our existing treatments, there are some people who unfortunately don't benefit. And I think that is the reality, that a lot of people who have trauma in their background really struggle with the CPAP machines because of just what it's like to have that on your face and really feeling like that's holding them down. So that sort of compliance with CPAP is a real issue. And I do believe that there's a lot of research being done into different ways of understanding different subtypes within obstructive sleep apnea and looking at different interventions to target the particular type of sleep apnea. So there is hope that will improve in the future. But the same is true of our psychological treatments that, unfortunately, they don't, even though we say they're evidence-based, that's because they're going to work for a lot of people, but it doesn't mean that they're going to work for everyone. So I think it is, as therapists, really going with the first-line treatment, seeing what can be done, but being prepared if that doesn't work, to think about other ways of helping to improve the quality of life, improve the functioning, even if the symptoms themselves can't be addressed very effectively.
And Andrea, can I ask you, this is really my question, but is there much evidence about, I found that your one of the points you made of recurring nightmares happening, together with apnea episodes. Is there evidence about that being more common amongst tortured or rather survivors of trauma in general?
Yes. There is. There are known risk factors for obstructive sleep apnea, and typically it's been associated with older people who are carrying more weight than they should be. But in trauma survivors, those factors don't seem to be present often. So, it's occurring in younger people of all different body weights. So there does seem to be something that is associated with the experience of trauma that we don't really understand at this point. But just observationally, it has been reported that rates of obstructive sleep apnea are higher.
Thank you. Thank you so much. Let's move to a question from Selena Wong-Ellery. And maybe that question really is relevant to both of you. So maybe Catherine, if you can go first with this one. And it reads, it was mentioned that evidence-based treatments should be considered before addressing nightmares with IRT. What if the client's poor sleep quality due to nightmares is affecting their ability to engage in meaningful therapy? Would this be an exception to address nightmares before PTSD symptoms?
Okay, yeah, that's a really good question. I think that we look at in terms of the phases that I would work through is assessing like their ability to handle, to process, to sit with uncomfortable sensations. That's so much of the work. Like I think that before we get to the desensitization phases, we want to build their capacity. We want to gauge so much about how willing are they to sit with uncomfortable, intolerable emotions and body sensations. How willing are they to stay present? The dual awareness, so like I'm here in the present now with you, and I'm aware that my trauma is in the past. I'd want to be screening for dissociation as well. I think that those are quite foundational phases. And I think that, so for me, if I was to work with them and to do any exposure or trauma kind of work, I'd want to see their ability to, if their sleep is impacting them, I'd want to ensure that they're present, that they're oriented, that they can shift from one state to another. I'd want to, yeah, they've got enough vagal tone to shift from like sympathetic and not going to dorsal vagal shutdown, that they're staying in their window of tolerance. I'd probably look at all of those things, their alertness, dissociation. I think if I'm answering the question, I think I'd approach it in those kinds of ways. And yeah, that could be a little bit of time to do that, to assess their stability. But yeah, I hope that answers a little bit of it.
No, thank you, Catherine. And Andrea, anything that you'd like to add to this question?
Yeah, look, I think just to say that if the sleep disturbance, even if they do have other symptoms of nightmares, if the sleep and nightmare disturbance is really prominent, and that seems to be a priority for the individual, I think that would be a good argument for why you might approach that first. There has been a little bit of research that's been done in recent years looking at what order these things should occur in. And I think there has been a bit of a mixed result. Some people would argue that if you treat the sleep problems first, then you're going to get better outcomes from the PTSD treatment. Others would say if PTSD treatment happens first, that might address the sleep problems, so you don't need to do two sort of interventions. But I think if there are good reasons for wanting to focus on the sleep disturbance first, I think that's very appropriate.
Thank you. Let's move now to a question from Lillian Harman, addressed to Catherine. And it reads, such a fascinating presentation, I imagine, so far. It was a brief present too. So far, Catherine, can you comment on the readiness criteria for EMDR standard protocol for asylum seeker clients without a stable recovery environment?
Yes, of course. Thanks, Lillian. That is a really key question, and there is some really fascinating literature that's really worth exploring. A lot of it comes from Dutch researchers and some from Syrian and Turkish researchers, where they're actually going into refugee camps, and they're actually utilizing EMDR in camps for refugees. So when we think about like unstable living conditions, and sort of all the psychosocial challenges and unresolved visa status, I think that when we go into a refugee camp, they're kind of the pinnacle of the most desperate and the most, perhaps as we perceive, non-ready or non-eligible clients. But the research is there. If you look in my references, I've got like some from Jackie van der Heide, Jurt Server, Atakirk, those kind of names. They're going into refugee camps and they're finding that the clients are responding extremely well to EMDR. There's also adaptations. So there's the recent episode protocol. So that's another modified protocol that Shapiro developed. And this can be used in a crisis situation. So after a humanitarian disaster in Ukraine, Palestine, I believe. So when we talk about withholding EMDR treatments for perhaps unstable living conditions, it is interesting to look that there are some clever protocols that Shapiro has developed. There's some interventions that have been done very safely and ethically ethically that I've researched there as well. So I think I'm giving quite extreme examples because I don't practice in a refugee camp. I practice in Starts at Liverpool. But I think it's very interesting to look at some of the research out there where treatment is, where the client's difficulty of their living situation doesn't preclude them from actually getting some of the trauma resolution that they really need. And then we want to think about the way that we carefully plan treatment, and we want to carefully select targets that aren't going to sort of cause them to sort of decompensate. I don't go for 10 out of 10 distressing memories first. I go for the moderately distressing memories and experiences first. So I do all of those. And I think we also fall back on those principles that we always use, that we always refer to by our governing bodies, like the APS. And we think about informed consent. And we think about, does the client fully consent to knowing that the benefit or this treatment could result in a reduction of affect and a reduction in their symptomatology. And if there's any secondary gains from having these symptoms, they want to be aware before they undergo. So we talk about informed consent. We also document everything very carefully. So I'm quite fastidious, like I do line by line, each way that the memory or the nightmare, in my case for Michael, is changing. And so they have the before, the pre and then the post, and all of that in between. So pages of notes. My supervisors see them. I'm a bit over the top, but it's very important to document everything clearly. And I think also we get objective measures pre and post from standardized measures to document that, like, the distress is very high, the symptoms are there, and afterwards as well. And I think it's also important, especially with some of these cases, that there's collaboration with solicitors and very careful and thorough documentation, and everything under the banner of good supervision and training as well. I hope that answers, but I could talk a lot more, but I hope that gives a bit of an overview there.
Thank you, Catherine. Let's go to a question by Lucy Meldrum now. It reads, I'm also curious about how you might modify this approach with young children or adults with complex developmental trauma, where the therapeutic alliance is more tenuous and receptivity to skills development may be low. Andrea, would you like to go first with this one?
Yeah, for sure. I think that it is the intervention in itself, in principle, would remain the same, I think, but you might take more time in establishing the trust. You might take more time in explaining the rationale, giving the individual as much control as possible so that they are the ones who are controlling the pace and the depth of the work that you're doing. As I mentioned before, the imagery rehearsal was first developed for children. And really those sort of archetypal dreams where young children dream that they're being chased by a monster, and in the most simple version, it was what's called face and conquer. So instead of running, the child rehearses just stopping, turning around and facing the monster that is chasing them. So I think that the complexity of the intervention can be adjusted to suit the client as well in terms of their age or developmental stage. One of the things that I haven't mentioned that I possibly should have done, and particularly relevant with complex trauma where people have had cumulative or several traumatic experiences or periods of their life that have been filled with trauma, what we often find is that the nightmares that they experience are not a discrete event, but are a mishmash or a combination of a whole lot of different events. And in those cases, I think that the approach is to try to work with the individual to identify a sort of archetypal dream, if you like, something that really captures the core elements of what happens in most of their dreams, at least, so that you're then working on that, and they then apply that to the variations of the dreams that come up. So I guess just in summary, it is just to say that while there's a process and you've got principles in your mind when you're working with imagery rehearsal therapy, people will use it in very different ways, and clients will want to make very different sorts of changes or be prepared to make very different sorts of changes, some of which might be very minor. And sometimes you'll think, well, I'm not sure why that is going to work if that's the only change they're prepared to make. But sometimes it does. So, for the therapist, also having an open mind about what might work and what might not, I think part of what is effective is that process of talking about it, putting it out there, and making it something that is looked at a little bit more objectively with someone else engaged in that alongside the individual.
Thank you so much, Andrea. Might move on to a question now from April Darling, which reads, some clients want to change the ending of a dream by imagining that they fought back or attacked the perpetrator in the nightmare. Could you please comment on the therapeutic effectiveness of such a suggested ending? And I might ask you both to comment on this. Catherine, would you like to go first on this one?
Yeah, a great question, April. It's very interesting. I actually had this, I've got the image of Michael in my head when we actually came to extreme needs to demonstrate aggression. Like, yeah, I think I mentioned this, like he wanted to bite his hand, he wanted to dig nails into his hand as well. There's this surge of anger that came up, this surge of aggression that came up. So Sandra Paulson talks about this, and Pat Ogden and Rothschild and all these wonderful somatic therapists. So what I would do is I would help the client to mindfully and meaningfully, with my co-regulation, even on Zoom, I would help them to safely discharge that energy that's been built up with that aggression that he wants to express, that his body wants to do. So I'd say, how does your body want to move in this instance? Let's do this. And the key is doing it slowly and mindfully. It's not like going into a rage, not doing anything unsafe. He had done that in the past, I will say that much. He has done like smashing things and breaking things. But through the process of EMDR and very careful attunement and guidance, he was able to sort of release some of that distressed, pent-up somatic sensations, and he was able to do that in ways that were safe and ways that were guided, and it was very, very effective. And again, there's a lot of somatic work, somatic therapists that expand on that in a lot of ways. You'll also see that through the free associations of EMDR, the client was so able to generate his own kind of fantasy-like but very therapeutic kind of resolution. And I say this word for word. This is not disguised. This is what the client said himself. He says, I can face my perpetrator, see them face to face, and they don't feel so threatening. So from EMDR language, I feel like that has become like his brain's way of facilitating and coming to a better resolution for a very distressing outcome. And the thing that I love is it's not generated by him, it's not generated by me per se, it's the process of EMDR allowed him to reconcile a very distressing aspect where he's been betrayed, there's moral injury, there's anguish, but he's generating that himself, and we see those distress ratings come right down. And yeah, that nightmare and the representation of reality in the nightmare is no longer has that intense emotional charge. So that's sort of my response to that question, April.
Thank you, Catherine. And Andrea, can I maybe take you to the other side of that question? You know, what about the therapeutic effectiveness of suggested endings that involve a level of violence in themselves?
So can I perhaps just start with the ending of a nightmare that involves confronting, you're changing that ending. So just in response to that question, I would say yes. You know, if you can change the end of a nightmare that increases the individual's sense of mastery or control, then that's going to have therapeutic value. But linking into your subsequent question, what if that involves violence? Is that therapeutic? And I think that again, we're talking about being clear about this is about not the memory, not the actual event, but just the nighttime experience. What we're wanting to do is have the person finish their dream in a way that is relaxing, in a way that they actually feel calm. So if the aggression at the end of the dream is arousing or is leaving them feeling agitated, then that's unlikely to be helpful. They're still likely to wake up from the dream, and they're still likely to wake up with that high level of arousal. So what we're ideally wanting to do, if you think about the adaptive function of dreams that are supposed to have an emotional processing function, and so after trauma, dreams will often start off as being replay, but will gradually morph into more symbolic dreams because that emotional processing is occurring. IRT, imagery rehearsal therapy, is really trying to promote that normal healing process by changing storylines so that the person will sleep through rather than wake up. So that's really the principle, I suppose. So whether or not it involves one action or another is less important than whether the individual feels that they can relax with that changed ending. Does that make sense?
No, absolutely. Thank you. We'll go to the next question, which takes us in a different direction. From Abu Sama Suri. And the question is, writing dream. What if one does not remember the dream they had? How do you work with clients that have, nightmares, but they cannot remember the content accurately?
That's a very short answer for me as far as the imagery rehearsal therapy, because if the individual doesn't remember the content, imagery rehearsal therapy is not going to be the treatment of choice.
Yep. There's another question that is got quite a few votes as well, and it reads, what strategies, techniques are recommended for people who have different nightmares that are not recurring ones?
I'm happy to start with that
Yep,
if you
okay.
like. Look, I think that in those cases, again, imagery rehearsal therapy is not likely to be the best approach because you do need to have a recurrent dream, except if you can identify some recurring themes. So if you can, even if they have different dreams all the time, but they always, for instance, someone who I worked with had just hundreds of different dreams, but they always involved him finding himself in an isolated place and under threat. So sometimes that would be in a city street, sometimes that would be in a different country, sometimes, it would be in different places. The source of the threat would be different. Sometimes it would be a gang, sometimes it might be a family member, whatever the case may be, but there was enough common elements to be able to say, well, this is the sort of archetype of your dream. This is what tends to happen. You find yourself in an isolated spot and then you're feeling under pressure from people or sort of under threat from people. So that's what we can work with. So that's the way I would adapt that. We're using imagery rehearsal. If that's not possible and if the dreams are just completely different all of the time, I think it would be more working through the sources of stress and anxiety in my approach to therapy is a cognitive behavioral therapy approach, and so I would be just working with them to identify what the underlying sources of stress and anxiety were rather than just targeting the dreams.
Thank you, Andrea. Catherine, you seem to be nodding earlier.
Sorry. Yeah, I'm nodding.
Yes, do you have any ideas you'd like to throw in about this couple of questions?
Yeah, sure. Sorry, I think I'd probably just go back to a considered case conceptualization. I'd see this as part of the holistic, many components of their presentation. I'd be thinking, okay, so there's like images, symbols that are recurring, but what else is happening as part of this client? Like, is there negative beliefs that are a theme cutting across these experiences? Is it like in Michael, I'm weak, I'm powerless, I'm whatever, out of control? Is there common emotions that need to be addressed and worked through? And I look at, because the adaptive information model which Shapiro developed to conceptualize everything is what we believe these are stored in networks. So it's very holistic. So dreams are part of it, absolutely. But there's also associated beliefs, body sensations and emotions. So if it's hard to pin down a dream or a memory or something to target, I would go in different directions. I'd look at the beliefs. What is it saying? What are you believing about yourself when you have this dream? Oh, I'm out of control. Okay, we go with that. Then what is the emotions that it's eliciting? Oh, fear, uncertainty, or something like that, or terror. I'd go in those directions, get a nice case conceptualization, and then we can hone in on the right things to target. And again, as Andrea said, they could be one could be representative or symbolic of the other. And I do believe the way that the AIP, the Adaptive Information Processing Model, conceptualizes clients' presentations, they are going to be somehow linked. And through the process of the therapy, those links will become more clear. So that's, I think, how I would work with that. If there's a little bit vague and intangible or various different images that are recurring in dreams.
Thank you. Might jump to a question from Luke Bell, that reads, I'm working with clients who state that they see faces and spirits in their dreams, and they wake up and see them in the room. What treatment modality would you suggest for this? Could drawing the faces or spirits help?
So, sorry, happy for me to start.
Yes.
There may be an element of a sleep disorder associated with that, where people can have a period between wake and sleep where they're not either awake or asleep, and it sounds like that might be happening where there's a bit of a lag of the dream mentation and the dream imagery that transfers into the waking state. So it may be worth assessing a sleep problem that might underlie that. That's one issue. The other issue is whether it's helpful to try and replace some of those frightening images of faces with more benign or even friendly or happy faces. And imagery rehearsal would be a great intervention to use to do that. So yes, I would say that would lend itself very nicely to imagery rehearsal therapy.
Thank you so much. I'm going to throw this last question from Angelique Caillou to both of you. We've only got 1 minute, so we'll have short answers. How effective is therapy for children and adolescents, and can it be modified? What is the evidence base around working therapeutically with young people experiencing nightmares?
Very quickly, the evidence base is strong for children as well as for adults, and it would just be adapted to be a developmentally appropriate way of working with the imagery rehearsal, including using pictures and images as well as written descriptions.
Thank you, Andrea. Catherine?
Yes, I'd use visuals. So I'd put scales on the pictures. I could use different toys and buzzy kind of things that you can buy. You can do other things to be less concrete, like we don't say validity of cognition out of 7. We do it very much child and developmentally appropriate. Parents can be there and tap on the shoulders as well. So there's lots of adaptations and lots of evidence to say that EMDR is very adaptable for young children and with parents in the room as well if they like. So that's my short answer.
Thank you so much. There's lots and lots more questions that we don't have time for today, which, it's been a fantastic presentation from you both. So thank you. I think it's been a privilege, for all of us, to have you presenting with us. And what a great end, to a series of clinical masterclasses for this year.